All right, let's jump right in and break down one of the most high-yield topics for your boards and, for real life on the wards, hypertensive disorders of pregnancy. Getting this stuff right is absolutely fundamental, so let's make sure you have it down cold. So here's our game plan. We're going to start with the single most important concept, that 20-week timeline. Then we'll use that to build our differential for the four main disorders. After that, we'll master how to diagnose preeclampsia with the new rules, learn to spot those critical red flags, and then wrap it all up with how we can actually prevent it in the first place. Okay, first things first, literally everything in obstetric hypertension hinges on one critical timeline. If you can understand this one dividing line, your entire diagnostic process becomes so much easier. So you see a pregnant patient with a high blood pressure. What's the very first question that should pop into your head? It's not just, is the pressure high? It's, when did it get high? The answer to that one question immediately chops your differential diagnosis in half. And here it is, the magic number, 20 weeks of gestation. It's that simple. If the hypertension was there before 20 weeks, or even before she got pregnant, we're dealing with chronic hypertension. But if it's brand new and shows up after 20 weeks, you should immediately be thinking gestational hypertension and preeclampsia. That's the fork in the road. Okay, so with that 20-week rule locked in our minds, let's build out our differential and see how this helps us classify the four main hypertensive disorders you're going to encounter. First off, what even counts as high blood pressure here? The threshold we care about is a systolic of 140 or a diastolic of 90 or higher. And this isn't a one-time thing. You need to see this on at least 2 separate occasions, about 4 hours apart. This is your ticket into the entire diagnostic algorithm. So this table basically puts it all together. Chronic hypertension, that's your patient who had high blood pressure before 20 weeks. Then you have gestational hypertension. This is new high blood pressure after 20 weeks. But, and this is the key difference, there's no proteinuria, no signs of organ damage. It just goes away after delivery. And then there's preeclampsia, which also starts after 20 weeks, but it's the one defined by that end organ dysfunction. And that brings us to the fourth category, which is kind of the curveball, superimposed preeclampsia. This is for your patient who already has chronic hypertension. You've been following her, and then after 20 weeks, things suddenly get worse. Maybe she develops new proteinuria, or her blood pressures go haywire, or she starts showing those severe features. That's superimposed preeclampsia. All right, let's really zoom in on preeclampsia for a minute, because this is where a lot of people get tripped up by old, outdated info. The old definition that absolutely required proteinuria is gone. You have to know the new rule. This is it. This is the whole thing right here. To diagnose preeclampsia, you need hypertension after 20 weeks, plus either proteinuria or any one of the severe features. You do not need both. This or is a massive practice-changing concept.
Now, if you're going to check for proteinuria, your best bet is the urine protein to creatinine ratio, the UPCR. Why? Well, because it's fast. Nobody, not the patient, not you, wants to deal with a 24-hour urine collection if they don't have to. A dipsticks is okay for a quick screen, but the UPCR is the quantitative test that gives you a real answer quickly.
And the magic number for that UPCR, 0.3. Easy to remember. If that ratio is 0.3 or higher, you've met the criteria for significant proteinuria. It's a key number to have in your back pocket. All right, now we get to what is probably the most important, most high-yield part of this entire discussion. The severe features. These are the red flags that tell you this disease is causing serious end organ damage, and it completely changes your management. And I'm not kidding. Pause this, take a screenshot, make flashcards, whatever you have to do. The presence of any one of these turns regular preeclampsia into preeclampsia with severe features, which puts the patient in a whole different risk category and often means it's time to deliver the baby. First up, the blood pressure itself. We're talking severely high pressures, a systolic of 160 or a diastolic of 110 or more. This is basically a hypertensive emergency in pregnancy, and you have to treat it fast to prevent a stroke. Next, you've got to think about the brain and the lungs. Is she complaining of a new headache that just won't go away, even with Tylenol? Or is she seeing spots or flashing lights? That's a sign of cerebral irritation. And you have to listen to her lungs. Any crackles, any sign of fluid building up, pulmonary edema, is a very, very bad sign. Now let's look at the labs. What's happening to the blood and the kidneys? Check that CBC and BMP. Are the platelets dropping below 100,000? That's thrombocytopenia. Are the kidneys taking a hit? You'll see that in a rising creatinine. Anything over 1.1 Or if it doubles from her baseline, that's a major red flag for renal injury. And finally, the liver. This is a big one. It can show up in two ways. You might see it on the labs with liver enzymes, your transaminases, climbing to more than twice the normal limit, or the patient might tell you. She might complain of that classic severe pain in her right upper quadrant or epigastric area. That pain is from her liver capsule stretching, and it's a huge deal.
Okay, so we've spent a lot of time talking about how to diagnose this stuff once it's happening. But what about getting ahead of it? Can we actually prevent it? The answer is yes. For some patients, we can significantly lower the risk. The strategy is actually pretty straightforward. First, you have to identify who's high risk. We're talking about patients with a prior history of preeclampsia, chronic hypertension, diabetes, twins, you get the idea. For these patients, the what is simple. Low dose, 81 milligram aspirin every single day. And when is the most critical part. You've got to start it early, ideally between 12 and 16 weeks, and keep it going all the way until delivery. So if you walk away with just 2 things today, let it be these. 1, know that 20-week cutoff. It's your anchor for everything. And 2, remember, you do not need proteinuria to diagnose preeclampsia if severe features are present. Master those 2 concepts, and you've mastered the fundamentals.
And that really sets us up for our next discussion. Because a diagnosis of preeclampsia doesn't just end at delivery. Pregnancy is like a cardiovascular stress test. And having preeclampsia, well, that's like failing that stress test. And it has major implications for a woman's future heart health. We'll dive into that next time.